This is Eric Hoverson, Clinical Practice 3, recording for presenting a patient on rounds. Patient X in bed 358 is a 15-month-old male here for a traumatic brain injury and as well as right subdural hemorrhages and bilateral retinal hemorrhages. This is hospital day 21, post-op day 21 from emergent craniotomy for evacuation of hematoma. The patient is stable and now on 3 South Physiatry. The patient had no acute events last night. Talking with his mother this morning, she said that he slept much better and seems a lot less irritable than previous nights. His vital signs, patient has been afebrile with intermittent low-grade temps, Tmax of 37.6. This happens every evening once around 7:30 or 8 p.m. He also has variable heart rate and blood pressures. His heart rates have been between 90s and 130s. His blood pressures have been systolics 90s to 110s and diastolics 40s to 70s. This variability is thought to be from his dysautonomia from his accident. He is on room air and satting at 96 to 100% without any oxygen requirements. His eyes and nose, the patient is not getting any maintenance fluids right now. He is on continuous NG feeds with formula at 40 mLs an hour and water at 12 mLs an hour. In the last 24 hours, the patient got 920 mLs of formula and 276 mLs of water and 27.9 mLs of meds for a total of 1223.9 mLs in intake. Output, he got 962 via weighed diapers. He is also stooling. This gives him a positive net of 261.9. Labs, the patient is on QAM sodiums from his brain injury. The last sodium today was 139. He's also on Q Monday and Thursday, CBC, CMP, and LFTs. His CBCs has been stable since he's been on physiatry floor with his last white count at 10.2, hemoglobin 9.3, and hematocrit 31.7, platelets 441. His CMP has been normal while he's been on physiatry as well. Again, sodium this morning 139, potassium 4.0, chloride 108, BUN 11, creatinine at 0.4, and glucose at 85. He is getting his LFTs checked because they have been high because while in PICU he was on continuous Tylenol. His last AST was 117, trending down from 138. His last ALT 104, trending down from 298. His prealbumins have been stable the whole time he's been here. Since he's been having the low-grade temperatures, we also checked his urine, respiratory, and blood culture, which have not grown anything to date, and his CRPs have been normal while he's been here, last one at 0.2. Since he is on heparin and Lovenox, his last low molecular weight heparin assay was 0.6. Imaging, the patient initially got a skeletal survey when he came to the ED, which showed no fractures. A repeat skeletal survey was done this week, which again showed no fractures. His post-op MRI of his head showed no reaccumulation of a hematoma, and he's scheduled for a follow-up MRI of his head today because he's been on Lovenox, checking for a bleed. He's on Lovenox for a right femoral vein thrombus, which happened after IV catheter was in there from the ED. Recent ultrasound showed that thrombus was stable, and he has a follow-up ultrasound scheduled on the 21st, a week after the Lovenox, to check on it. Tubes, he has an 8 French NG tube secured to his left nair for his continuous feeding, his PICC line in his left bacillus, No IV fluids are going through that, but again, we're doing frequent labs, and that is why he still has that. Medications. The patient is on Onfi and Keppra per neurology's request. He had 2 seizures en route to the hospital. He's on clonidine and gabapentin for neurostorming, as well as a clonidine for the sedation wean. He's on Lovenox and heparin for his right femoral vein thrombus. He's on melatonin every day for sleep-wake cycle. And he is on methadone for his sedation wean as well. He has Miralox and Senna for his bowel regimen. And he is on sodium chloride, which is being weaned. He's on that because of his tier 3 TBI protocol that he was on to keep his sodiums above 150, which has been liberalized. His PRN meds available. He has acetaminophen for pain and fever, Ativan and morphine for agitation, Ducalox for constipation, and Narcan for overdosing. His physical exam. His head, general state. He was laying in his crib with his mother at bedside this morning. Fussy intermittently, but able to be consoled by mother holding him or touching him. His head is normocephalic with a zigzag incision to his right frontoparietal area, without any signs of edema, or exudate. His eyes has spontaneous opening. He does not tract. He does have a corneal reflex. His pupils are reactive but slightly sluggish at 3 to 4 millimeters bilaterally, and he has no blink to confrontation. His oropharynx is clear. His mucous membranes are moist. He does have a lot of salivation or siluria in his mouth, but he is able to swallow. He has tongue fasciculations. We are assuming that this is from his accident. They have improved since we have increased his clonidine back on the 15th. His lungs are clear bilaterally to auscultation. They are symmetric in expansion and non-labored breathing. His pulse is 2+ bilaterally. Abdomen is soft and non-tender, non-distended. He does again have spontaneous eye opening. No tracking is noted. He positive corneals. No blink to confrontation. He'll turn his head to sound or touch. He favors his right side. He has spontaneous, non-purposeful flexion and movement of his right arm, hand, and fingers. His right lower extremity has hip, knee, and toe movement, but not a lot. He has left hemiparesis with left neglect. We have not seen any movement on his left side, although his mother states that he has moved his hand a little bit. He has bilateral upgoing toes, hyperreflexive bilateral patellars, and positive grimace, cough, and gag. His sensation is hard to assess, but he does cry when he receives a shot on both sides of his thighs. He has full passive range of motion to both bilateral shoulders, elbows, wrists, hips, and knees. The assessment on this patient. This is a 15-month-old boy, status post head trauma from a fall from a kid's standing on top of a kid's table with resultant right subdural hematoma, bilateral retinal hemorrhages, and diffuse ischemic event to bilateral occipital and frontal areas. Plan neuro. Patient has left hemiparesis with neglect. His neuro exam appears to be stable with modest improvements in tone and spasticity. Minimal amount of movement has been reported in the left and upper and lower extremity. Neurology is as well consulting. We're doing the methadone wean. Next wean is scheduled for this Sunday the 20th. We're going to continue his Neurontin TID and his clonidine for neurostorming and neuroirritability. His irritability seems to be improving, and he is starting to be able to self-soothe. We're going to continue Ativan and morphine PRN for high Watt scores. Neurosurgery said that it's okay to liberalize his sodiums back down to normal 135, 145 range, and so we are starting to wean his sodium supplements. His last wean was yesterday, and his next wean will be on Saturday. He is scheduled for a fast-acting MRI of his head today to evaluate for hemorrhages because he's on Lovenox. ENT, we're going to continue to monitor his salaria because he has excessive salivation in his mouth. This is improving with chest PT, and so we're going to continue the chest PT Q8 hours and as needed. He will need a hearing screen at some point. Optho is following for his bilateral retinal hemorrhages. They followed up, eval'd him on the 16th and said that those hemorrhages are improving but still there. CV, he has dysautonomia. The clonidine is being used to help with this, as well as his sedation wean. He has his left upper extremity pick. We're going to continue with this for now because of his frequent labs, and we'll assess pulling this early next week when we can switch labs to Q weeks. He has his right femoral thrombus, which we'll talk about with heme. He's on Lovenox and heparin for this. His next ultrasound to check on the thrombus is on the 21st. We checked his heparin assay, and it's at 0.6 after the second dose, and we will recheck that again on the 21st. Again, he's getting a MRI today to check his head for bleeding because of the Lovenox. Respiratory, he's on room air, satting appropriately, chest PT, Q8 hours, and PRN. FE and GI, he's tolerating his NG feeds at goal, continuous feeds right now. We will, no nausea and vomiting have been reported, and so we will attempt to transition him to bolus feeds next week. He may end up needing a G-tube, but we'll visit that next week, depending on how the bolus feeds go, and whether he ST speech therapy evaluates him, and the possibility of him feeding again quickly. We're going to continue with CMP and LFTs, watching his AST and ALT because of him being on Tylenol. They are trending down. A dietitian has been consulted and is following, and he has Senna and Marilax for his bowel regimen. We're going to continue with that. GUs per diaper, and he's doing well with voiding and stooling. Musculoskeletal, no fractures have been noted on his survey. Hanger has been buy and fabricated multi-potus boots bilaterally for him, and hand WHFOs. We're going to continue to use those alternating on and off every 2 hours. We need to monitor for pressures. If you do see pressures on any areas from these boots or hand splints, you can use Mepilex to prevent. Social worker is involved, and CPS is investigating to make sure that this was not a NAT.